Hi everyone, this is medical oncologist Dr. Neil Love from Research to Practice with an important update to this presentation. On March the 14th, the FDA approved lisocabtagene maraleucel for patients with relapsed or refractory CLL or SLL after 2 prior lines of therapy, including both BTK and BCL2 inhibitors. Liso-cel is now the first and only CAR T therapy approved for patients with relapsed refractory CLL.
Good day, everyone. It's great to be here. I am Bita Fakhri. I'm an assistant professor of hematology with the Stanford Cancer Institute. And I'm here to talk to you about the updates in CLL, which happened at ASH and EHA 2023. And this is how I'll be driving the talk. So as you know, on February 12, 2014, almost 10 years ago, ibrutinib got approved for patients with relapsed refractory CLL, and that truly transformed the field of CLL. And CLL became the first leukemia to leave chemoimmunotherapy behind, and targeted agents made their way to both the frontline and relapsed refractory setting. So when we think about treatment options for patients with CLL, there are 2 major categories: patients who are treatment naive and patients who are relapsed refractory. And I will then introduce the concept of double refractory, which is a more emergent concept in the recent years. And there are 2 major treatment approaches. One of them is treat until disease progression or intolerance, and that's where the Bruton tyrosine kinase inhibitors come into play. And then the other approach is time-limited therapy with venetoclax or BCL2 inhibitors, and we'll try to elaborate on both treatment approaches. When it comes to treat until disease progression or intolerance with BTK inhibitors, the trials that are shaping the landscape currently and in the next few years in terms of treatment naive patients, patients who haven't been treated for their diagnosis of CLL in the past, I will talk to you about the 6-year follow-up of Elevate-TN trial, which basically compared acalabrutinib single agent to acalabrutinib obinutuzumab to combination of obinutuzumab chlorambucil. The Sequoia trial resulted in the approval of zanubrutinib when it compared zanubrutinib to bendamustine rituximab in the frontline setting in January of last year, January 2023. And I'm not going to elaborate on the results as it was presented at ASH 2022. And when it comes to relapsed refractory setting, we do have the Elevate relapsed refractory trial, which compared acalabrutinib to ibrutinib in a head-to-head fashion. And then the 39-month follow-up of the Alpine trial, which compared zanubrutinib to ibrutinib, is being presented here. It was presented at ASH by Dr. Jennifer Brown. And in terms of time-limited therapies, the CLL14 trial presented its 6-year follow-up at EHA this year. And this is a very important trial for many reasons that I'm going to go into detail. And then there is an emergence of doublet and triplet therapies with the hope that if we combine BCL2 inhibitors and BTK inhibitors and CD20 monoclonal antibodies, we are able to give our patients a prolonged duration of remission and also give them the opportunity to have time-limited therapy without being on a medicine potentially lifelong. I will present an update on the Captivate trial, which was a phase 2 combination of ibrutinib plus venetoclax. I will talk about the phase 3 GLOW trial. They presented their 57-month follow-up at ASH 2023, and a very well-designed trial. The UK FLAIR also presented its results at ASH this year. And these are all time-limited therapies combining a BTK inhibitor, which in all 3, the BTK inhibitor of choice was ibrutinib, plus venetoclax, the BCL2 inhibitor. The Murano trial has been published before. It is a 2-year combination of venetoclax plus rituximab in the relapsed refractory setting. And again, in the relapsed refractory setting, the course of venetoclax is for 2 years, and it's also time-limited in that sense. And then there is a new concept, and that is double refractory patients. And I want to make sure that we all understand double refractory. Double refractory and double exposed are two very different topics. Double exposed patients are patients who have seen a covalent BTK inhibitor and a BCL2 inhibitor in the past without necessarily having developed resistance to either agent or one of the agents. But double refractory patient population, those are patients who have developed resistance to both covalent BTK inhibitors and also BCL2 inhibitors. And this is a very contemporary patient population in CLL, because in the last decade, with the emergence of all these new medicines, covalent BTK inhibitors, ibrutinib, acalabrutinib, zanubrutinib, the BCL2 inhibitor, venetoclax, obinutuzumab, these patients basically enjoyed meaningful remission and disease control. But we are seeing an increasing number of patients with CLL, particularly with negative prognostic features like TP53 aberrant disease, unmutated IGHV, who are becoming refractory to both classes of agents. And the question is, what's next for those patients? The BRUIN trial introduced the first non-covalent BTK inhibitor, pirtobrutinib, which got accelerated approval for this very patient population, double refractory patient population, on December 1st, 2023. So pirtobrutinib is now available to the double refractory patient population. BTK degraders, that's a new class of agents. It is not ready for clinical practice yet, but there are 3 clinical trials that are at early stages, and they're going to become more mature. The data is going to become more mature in the next 5 years. And then cell-based therapies, the Transcend CLL 004, which investigated lysocaptogen marrow-cell, the CAR-T product in CLL, was presented at ASH, and they actually focused on a double refractory cohort. And bispecific T-cell engagers, epcoritamab, CD3 and CD20 bispecific T-cell engager, and also glofitamab. Those are the 2 bispecific T-cell engagers that are currently being investigated in patients with CLL and also Richter syndrome. And they have an exciting future, which are going to be presented in more depth and once they have more data at future ASH meetings. So the outline of my talk, I'll focus on the frontline CLL trials, and then I move to relapse refractory, eventually double refractory, and last but not least, Richter syndrome. My old mentor used to call Richter syndrome the orphan disease, because these are patients, particularly in the DLBCL transform type, they're historically they've been excluded from diffuse large B-cell lymphoma trials, and they're also excluded from CLL trials. And we know that the outcomes of these patients are very poor. So the CLL14 trial presented its 6-year follow-up. CLL14, as you probably know, enrolled patients with treatment-naive CLL, and it is very important to note that CLL14 truly enrolled old and unfit patients with multiple comorbidities, as evidenced by cumulative illness rating score of greater than 6, and the inclusion criteria required a creatinine clearance of less than 70. So truly did not cherry pick patients for this trial. And it randomized patients in a 1-to-1 fashion to receive venetoclax for 1 year and roughly 6 cycles of obinutuzumab versus chlorambucil obinutuzumab, which was the standard of care based on the CLL11 trial for old and frail patients. And here you see that the 6-year progression-free survival was 53%. And I always pause and try to translate this data for my patients. It means in patients who received 1 year of venetoclax, time-limited therapy, and 6 cycles of obinutuzumab, they enjoyed a 5-year treatment-free remission. And at 6 years, 1 year of treatment and 5 years of being treatment-free, 5.5 out of 10 patients are still in remission. And that is pretty incredible for a time-limited therapy. And in terms of overall survival, you see that the 5-year overall survival was close to 80%. And then the question is time-limited therapy the right choice for patients with high-risk genetic features? And here you see that the data on the left for patients with TP53 aberrant disease. So the median progression-free survival for patients with TP53 aberrant disease is 52 months. And this is really, it depends on what kind of doctor you are. And I think we have to make sure that the patients are understanding the data. So if you think taking a combination in a TP53 aberrant disease patient for 1 year and then they're going to 51 median progression-free survival of 52 months means they can potentially enjoy 3 years of being treatment-free, and then at 4 years, their disease, the median was 52 months, is likely to come back. If that's acceptable to you and your patient, that's a potential option. But there are, many investigators in the field who think that we should do better for patients with TP53 aberrant disease. And in terms of unmutated IGHV, the median progression-free survival was 65 months. Again, meaning patients took 1 year of combination, and then they enjoyed a 4-year treatment-free remission, and then their disease was likely to come back based on the median. And then again, it depends on whether this is acceptable to you and your patient or not.
So I know this is kind of a global, perception, but I'm kind of starting to see trials that show survival benefit in CLL, and I kind of haven't been expecting it. And I don't think I've really been seeing that until fairly like you just showed. I don't know if that's statistically significant, but it looks pretty different. Like, what do you think's going on, and what are people dying of?
That's a great question. It's actually a very prominent to see overall survival benefit in any of the CLL trials, because now we know that patients who progress, they have a menu of very good options that they're going to get on, and they're going to live longer. So a lot of patients with CLL, they have inherently dysfunctional immune system. COVID was hard, especially in the beginning of the pandemic, on many CLL patients, and we lost, lots of life in patients with CLL to COVID. Infections in general are a major cause of morbidity and mortality in patients with CLL. So basically, complications of hypogammaglobulinemia and immune deficiency are one of the major causes of death in patients with CLL. And then Richter syndrome, it happens in 2 to 10% of patients with CLL, but it is a dire diagnosis, and unfortunately the field has not done much to advance the outcomes of patients with Richter's yet. There is more data coming out with bispecific T-cell engagers, with a combination I'm going to present of BTK inhibitors and anti-PD-1 inhibitors, but it is a disease with a median overall survival of 3 to 9 months based on what registry you're looking at. The French registry, the American registry, the median overall survival is about 3 to 9 months. So the majority of patients are succumbing to the immune deficiency, which is inherent to their disease, or Richter syndrome, or really bad accelerated CLL progression. And those are mostly patients with TP53 aberrant disease. That, they unfortunately do not respond to, they do respond, but the responses are not durable, and they run out of options, and we don't know what to do with them reliably at this point.
Yeah, I kind of wonder whether or not, infection as a cause of death sometimes is a little bit tricky. It's, certainly different than somebody who has progressive disease. And I was kind of wondering whether or not maybe COVID just sort of accentuated that, and now we're kind of seeing it in the trials. And maybe it was there all along, but just COVID allowed us to see it better.
Yeah, COVID was sobering in terms of bringing that problem to surface for patients with CLL. I totally agree with you. Moving from CLL14, the Dr. Peter Hillman from the UK group presented the data of the FLAIR study, and on the very same day, it was published in New England Journal of Medicine. FLAIR was a study that enrolled north of 1,700 patients between 2014 and 2021, and for the sake of his talk, they compared the ibrutinib plus venetoclax arm to time-limited therapy with fludarabine, cyclophosphamide, rituximab. So they enrolled patients with previously untreated CLL who required therapy, and they were considered fit because they're randomizing patients to potentially a chemoimmunotherapy arm and less than 75 years of age, which is considered young for a patient of CLL with CLL. It's a disease with median age of 67 to 72 years of age. And they excluded patients with Richter's transformation and greater than 20% TP53 deletion by FISH. And patients got randomized to 6 cycles of FCR or a combination of venetoclax ibrutinib, and the primary endpoint was PFS, and secondary endpoint MRD overall survival, and safety and toxicity. So they had a very interesting mathematical model for when to stop therapy. And I'll try to briefly touch up upon that because it's very novel in that sense. So it was not a one-size-fits-all. It was MRD guided. And how they did it, after 1 year of combination therapy, they checked peripheral blood MRD. If a patient had achieved UMRD, or undetectable measurable residual disease, then they rechecked MRD in peripheral blood 3 months later. And if that was still negative 3 months after the second measurement, they rechecked MRD both in peripheral blood and bone marrow. And if all four values, peripheral blood T0, peripheral blood T3, and peripheral blood and bone marrow at T6, 6 months, were all negative, then the very first time that their peripheral blood results were negative, they marked that time point, doubled it, and that became the duration of therapy for that particular individual. So if a patient's first negative MRD result was at 1 year, then that patient was committed to take 2 years, 1 times 2, 2 years of combination therapy. If someone became MRD negative at 18 months, that patient had to take 3 years. So the duration of treatment was 2 to 6 years for patients. And here you see that the 9-month complete response rate was 60% for the doublet versus 50% for the chemoimmunotherapy, with an overall response rate of 86% versus 76%. Something very important, you see that at 2 years, about half of the patients stopped treatment on the bottom left graph. And at 3 years, 63% of patients stopped treatment. And at 4 years, 73%. And the results were differential based on IGHV mutation status, which is fascinating. You see that patients with unmutated IGHV, which is known to be an adverse prognostic feature, achieved UMRD at a faster rate, as evidenced by at 2 years, 57% of patients with unmutated HIV stopped treatment as compared to 40%. At 3 years, 75% versus 50% in the mutated IGHV, and at 4 years, 85% versus 60%. And it's really important to realize that our good risk feature patients with mutated IGHV, they're not necessarily achieving UMRD, but they're having really good results as compared to unmutated IGHV, which are achieving UMRD at a faster rate. And we know that they need that UMRD for a durable response. So here you see that the primary endpoint, PFS, the 3-year PFS was 97% in the doublet group versus 76%, meaning 2.8% of patients at 3 years progressed with the doublet. And the overall survival, here you see that also there was a difference, as we just talked, in overall survival in the doublet versus FCR. So there were 9 death events in the doublet versus 25 deaths in the FCR group. And talking about what were the potential causes of death, we'll get back to that, including secondary malignancies. And this is another very important graph. So you see that unmutated IGHV, the difference was more stark between the doublet and FCR. So we know that patients with unmutated IGHV, those are patients that do not respond well to chemoimmunotherapy. And in terms of mutated IGHV, yes, there is a trend toward improved PFS and overall survival with the doublet, but that did not necessarily meet the statistically significant threshold. And in terms of secondary malignancies, you see that there were 39 secondary malignancies with chemoimmunotherapy as compared to 17. And the majority of those secondary malignancies were non-melanoma skin cancers. So lots of questions and thoughts. This was a very sophisticated design trial. And one of the big trials, which the duration of therapy was MRD guided. But I am a little uncomfortable with labeling or advertising 6 years of therapy as time-limited therapy. In my mind, time-limited therapy is 1 or 2 years. 6 years of being on doublet therapy, I'm not sure if I'm comfortable calling that time-limited therapy. And from this trial and the next trial that I'm going to show you, you see that unmutated IGHV patients, they achieve UMRD, they achieved the UMRD faster, and they needed UMRD to have better PFS outcomes as compared to mutated IGHV patients who actually did not necessarily, with prolonged treatment course, did not achieve UMRD state, but even those with positive MRD still had really good PFS outcomes. So the question is, should we use the MRD guided approach for all patients, or really use that for a subset of patients with high risk features? Because otherwise we are over-treating our good risk feature patients, and I hate over-treating mutated IGHV patients.
Just a quick question about the non-melanoma skin cancers. Any thought about what's going on there?
Yeah, I mean, inherently dysfunctional T cells are the reason that patients with CLL in general are at an increased risk of developing non-melanoma skin cancers. And also, if they develop it, really more severe forms. That's why all our CLL patients, they require at least an annual dermatology skin check from head to toe, not by their hematologist, because lesions that might not look anything to a hematologist's eyes, a trained dermatologist can catch them pretty early on and remove them. So because of those inherently dysfunctional T cells, patients with CLL are at an increased risk of developing non-melanoma skin cancers. And here, in the chemoimmunotherapy arm, we're getting rid of our good cells and we are enriching cells with bad features, so that risk actually becomes more accentuated.
I was just thinking about the fact that you see non-melanoma skin cancers in people who've had transplants and are, GVHD, and then I know ibrutinib is sometimes used in GVHD. So is that also an issue? Not just the fact that the disease is not being as well controlled, but something about what ibrutinib does or BTK does immunologically.
I think ibrutinib, because of its not very selective BTK inhibition, has that advantage of immune modulation. And that's, something that we are taking advantage of in our CAR T trials. The Transcend had an arm for ibrutinib plus CAR T to enhance the function of T cells. So ibrutinib in the class of covalent BTK inhibitors definitely has that advantage. And just to quote Dr. Michael Halleck, it's very important to remember that BTK inhibitors, they're not like BCL2 inhibitors. They're not pro-apoptotic agents. They don't tell a CLL cell to go and kill yourself. They don't kill CLL cells. They change the dialogue between the CLL cell and the microenvironment, and that potentially can contribute to immune modulation also. And then in that line, talking about doublets, GLOW was a phase 3 trial. This is fixed duration. So this is the difference between GLOW and FLAIR. GLOW was fixed duration ibrutinib plus venetoclax versus chlorambucil obinutuzumab for 6 months. They presented their 57-month follow-up. The trial designed randomized patients in a 1-to-1 fashion to receive ibrutinib for a lead-in period for 3 months to debulk CLL. So when we introduce venetoclax after 3 months, patients are going to be at a lower risk of developing tumor lysis syndrome. And they randomized, the other arm of the study was chlorambucil for 6 cycles combined with obinutuzumab. The primary endpoint was PFS. And they presented their 57-month follow-up. And here on the top part, you see that the 54-month basically PFS was about 66%. The 57-month PFS was 65% with fixed duration, 1 year of combined therapy, as compared to only 20% with chlorambucil obinutuzumab. And then they looked at IGHV mutation status. The doublet showed that only 1 year of therapy, you see that the 54-month PFS for patients with mutated IGHV was 90%. I'll come back to this and try to tease out some information. And for unmutated IGHV patients with fixed duration therapy, not MRD-guided therapy, that 54-month PFS was 60%. And as expected, patients who did achieve UMRD had a more prolonged PFS compared to patients who did not achieve MRD. And then the study did something really sophisticated, studying the interaction between MRD status and also IGHV mutation status. And here in the orange lines, you see that in patients with mutated IGHV, even if they did not achieve UMRD state, even in patients with positive MRD, their PFS was still really good. The two lines almost overlap. Again, basically raising the question, do we need to aim for UMRD in our mutated IGHV patients? But in unmutated IGHV, patients who did achieve UMRD, they did almost as well as patients with mutated IGHV. But patients with unmutated IGHV who did not achieve MRD negativity, they did not have good progression-free survival outcomes. And here you see that at the end of treatment plus 3 months, about 55% of patients achieved a UMRD state. And at the end of treatment plus 38 months, that number is at 32%, meaning almost 60% of patients remained their UMRD state. And really interestingly, if you look at the left, patients with mutated IGHV, yes, they achieve UMRD at a basically lower rate, but they tend to maintain it. As you see on the left, it remains around 40%, 38 months after completion of therapy. Whereas on the right side, you see that in unmutated IGHV, those are patients who tend to lose their MRD negativity state. And in terms of subsequent therapies, in patients who did progress, 26 patients progressed in the doublet arm versus 75 patients in the chlorambucil obinutuzumab arm. And out of those 26 patients, 14 patients did not require a new line of therapy. And that's the beauty of a chronic malignancy like CLL. The minute you progress, that doesn't mean that you have to get on the new line of therapy. And of those 12 patients who required a new line of therapy, 6 patients were rechallenged with the very same covalent BTK inhibitor that they got during their fixed duration therapy. And I think this is really important information to present to our patients. On the right, you see the treatment-free survival with 57-month follow-up. The 54-month treatment-free survival in the doublet arm is almost 75%, meaning at 54 months, 75% or 3 out of 4 patients are alive and not requiring getting on a new line of therapy. And that's an information that it's important to share if patients are being considered for doublet ibrutinib plus venetoclax. And I know and I acknowledge that cross-trial comparison is fraught with bias, but I can't help but putting this here. FLAIR was an MRD-guided approach, but GLOW was a fixed duration approach. So you see that the 3-year PFS for mutated IGHV patients in FLAIR, where patients got 2 to 6 years of therapy, is 94%. In GLOW, where patients got 1 year of doublet therapy, a much shorter time, the mutated IGHV, the 54-month PFS is 90%. So again, highlighting the fact that maybe our mutated IGHV patients do not need MRD-guided approaches for good PFS outcomes. But in unmutated IGHV, you see that the 3-year PFS in FLAIR, where they did use a very smart MRD-guided approach, is 98%. But in GLOW, when they used one-size-fits-all, only 1 year of doublet therapy, the 54-month PFS is 60%. Again, highlighting that the MRD-guided approach makes a lot of sense for patients with unmutated IGHV.
So maybe you're going to get to this later, but I've got to ask you right now, as long as you got it up there, is this something you're doing in your practice or you'd like to do in your practice?
Yes, I want to, be very loud and clear that MRD data, we are doing a lot of work on our clinical trials. They are a huge part of many of the trials that are currently going, and they're an essential part of any clinical trial design in the future. But outside a clinical trial, MRD results should not guide duration of therapy for patients. And I'm very clear with patients that we have learned a lot, but it's still an intellectual exercise for the field. So, in CLL, if I treat a patient in the front line with venetoclax or obinutuzumab, and at 15 months, which is 3 months post completion of therapy, they're MRD positive, I share that information with them. But I'm like, I will tell them that there is no data, as you and I are speaking right now, that an additional year of therapy or an additional period of therapy is going to benefit you. We are running trials, but those results have not read out yet. And, the same, if I have a patient on the Murano trial, I say the same thing. If I'm giving a patient venetoclax in the relapsed refractory setting for 2 years, at 2 years, I stop regardless of MRD status. And it is very likely that patients with MRD positive results, their disease come back. But, it's also important to understand that MRD in CLL is different from MRD in diffuse large B-cell lymphoma, MRD in acute leukemia. CLL is a chronic malignancy. And I never use snapshot values for determining long-term prognosis, because sometimes we know there are patients with low positive MRD who go on forever without progressing. So why do we have to hit them hard? But there are patients who are MRD negative at one snapshot, and then longitudinally you follow them and they become MRD positive in the future. And those are patients who are at a much higher risk of clinical progression later on. So MRD, I don't use MRD to determine duration of therapy outside a clinical trial in my practice. And I'm very open and frank with patients that we are still learning about MRD and clinical applications in CLL.
Doing a thing this morning on prostate cancer. It doesn't seem that much different than intermittent androgen deprivation. But another question I had, kind of a basic question, but you referred to it before. When you have a patient who relapses, do you use the same criteria to start a second therapy that you do in the beginning? Being symptomatic,
That's a beautiful question. Yes, I am, of course, in the relapse setting. I am more vigilant, but patients are also more vigilant. They've learned about their disease and they know when, it's time for them to start therapy. But I use the very same IWCLL criteria for initiation of therapy, including B symptoms, constitutional and compressive symptoms, rapidly progressive cytopenias, lymphadenopathy, splenomegaly, autoimmune processes associated with CLL, Evans syndrome, and, the absolute lymphocyte count doubling of 6 months. It's really important to develop a clinical sense. I'm not as strict. If someone has a lymphocyte count of 20,000 and in 6 months it's 45,000, yes, it has doubled. But if they have a good hemoglobin, if they have a good platelet and they don't have any other reason to be treated, I'm comfortable watching that with the knowledge that their CLL is likely not a dormant CLL. It is going to progress. But that very moment, because they've doubled their absolute lymphocyte count, is not, necessarily the time to just, start therapy.
What about risk status? And the reason I ask this is I think there was a paper, it might have been at ASH, which looked at treating, I think it was mainly del-17p, and they didn't see any benefit. But the thing that I thought was interesting was that they used this model. This is, again, first-line treatment now, not relapse. But I guess you're saying it's a similar idea. So they used the model to predict that, when they would relapse, and they got, quote, higher-risk people in there. And even though the study was, quote, negative, I was impressed that when you use that model, it looked like you could see that they're going to relapse, and some of these people are going to relapse within a year. And, I could see maybe treating somebody like that. But and so this question relates not just to recurrence, but even up front, what your thoughts are about that.
Yeah, the paper that you're referring to is the CLL-12 trial, ibrutinib versus placebo in patients with CLL,
right.
Treatment-naive CLL.
Right.
And, you are right. It was a negative study, but, that's the beauty of negative studies. We learn so much from negative studies. So yes, we know that patients with high-risk features, patients with TP53 aberrant disease, unmutated IGHV, complex karyotype defined as 3 or greater than 3 chromosome abnormalities, those are patients that they are not going to go through life without treatment. And, we are doing a similar study in the U.S. The SWOG group has basically a trial of randomizing patients who do not meet the IWCLL criteria for initiation of therapy, but they are high risk based on the CLIPI score, CLL IPI score, and they randomize those patients to just watch and wait or 1 year of obinutuzumab venetoclax. I think that's also a trial that is going to answer that very question, hopefully in the next few years.
And I don't know how high risk those patients were, but I mean, my point is the control arm here didn't. If you know that it's very likely you're going to relapse in a year, even if you're not symptomatic, to me, it seems, fairly logical to at least consider treatment. I mean, would you do that?
So it's, if basically it's really a mutual decision making. I always tell patients that, there's a simple philosophy in oncology that the treatment should not be more toxic than the disease. So even if you have TP53 aberrant disease, and your disease has started coming back, as we see in your labs and as we see in your lymph nodes, I try to bring in those patients more frequently, every 2 months, every 3 months, and I try to educate them profusely and have them develop the understanding that treatment is in their future, but the timing, the exact timing, if they're eager to treat, by all means, if their fatigue is at a level that they can't go about their day, we have every reason because they're basically numerically progressing or based on the physical exam, they're progressing. But, patients have a loud say. If they feel like they are comfortable with watch and wait and they will come back to you when they feel like it's time for them to get treated, then we just continue the expectant management. But I do not let those patients to just go and come and see me 6 months or 12 months later. I try to increase the frequency of their follow-up visits just to make sure that we don't miss anything, any raging progression.
I don't know, for some reason, I just flashed on a case. We've had so many cases presented, particularly in the last few years, of a patient who went on the intergroup study of ibrutinib versus FCR because he couldn't get ibrutinib. It was, 2014 or before, and he got randomized to chemo and got cured and still regrets it because he has all these problems from the FCR. But it's kind of interesting that they went on it to get the ibrutinib and he got randomized to the other arm and probably got cured.
Yeah. Yes.
That's a real person, actually.
Yeah. I mean, there are a lot of stories like that for sure.
I'll bet.
Yeah.
All right, Captivate.
Yep, Captivate, just to present the 5-year follow-up and also a very important question that Captivate is trying to answer with clinical application is, okay, what happens to patients who progress after doublet therapy? Because there are some critics of doublets and triplets who might say, if you give your best agents in the front line, you're taking away the opportunity of responding to these agents sequentially later in their CLL journey. And Captivate is trying to answer this question in this presentation. So Captivate had 2 cohorts, fixed duration and MRD based. In the fixed duration, patients got 3 cycles of ibrutinib followed by 12 cycles of doublet therapy, ibrutinib venetoclax. And in the MRD cohort, so at the end of 12 cycles of ibrutinib venetoclax, everyone got checked for MRD. And if they had confirmed UMRD, they got randomized to either placebo or continuing ibrutinib. So for the sake of this study, they also included the placebo group because those are also patients that actually stopped. They didn't take anything. So they had 202 patients treated with fixed duration ibrutinib plus venetoclax, 159 in the fixed duration cohort, and also 43 in the placebo cohort of the MRD cohort, placebo sub-cohort of the MRD cohort. And of those patients, 53 patients of 202 patients have progressed, 4 of them with Richter's transformation. And for the sake of this study, I'm going to focus on the 49 patients with CLL who progressed. So you see that the majority of progressions, 2/3 of the progressions happened after 2 years, and 1/3 of progressions happened sooner than 2 years. And the majority of early progressions were rich in patients with complex karyotype and also patients with deletion 17p and or TP53 mutation as expected. And when you looked at the resistance mutation panel, none of those patients, in the 40 patients that they could actually do next generation sequencing, none had developed a resistance mutation to either BTK. We know that the most common resistance mutation to BTK is CYS481. And they didn't have any mutations to BCL2 either, the most common mutation to venetoclax being G101V. There was only one patient with a mutation in A113G, which actually has been reported as a co-mutation with G101, but as an isolated mutation does not have any clinical significance. And it is important because this trial shows that time-limited therapy approach does not result in emergence of resistance mutation, which can result in progression of disease if you're treating someone indefinitely with BTK inhibitors or for a very long time with BCL2 inhibitors. And of the 53 patients with progressive disease, 18 patients have not required a new line of therapy. 28 patients have required a new line of therapy. 22 of those patients are being treated with single-agent ibrutinib, and 6 of those patients with a combination ibrutinib-venetoclax. And those 6 patients, their progression had to happen after 2 years for the investigator to be allowed to reuse and re-challenge venetoclax. And here you see that in patients, 21 patients with single-agent ibrutinib, the overall response rate of ibrutinib re-exposure is still very high at 86%. And in the doublet arm, the overall response rate is 83%. And here you see that with 5 years of follow-up, the 5-year PFS is about 70%. And when you break it down but by high-risk features such as IGHV unmutated status, 11q deletion, and complex karyotype, the 5-year PFS remains mostly similar in those 3 groups with high-risk features, but it's patients with 17p deletion that their 5-year PFS is not good at 45%. So I think this trial was very important in answering an important clinical question in the field. What are we going to do after someone progresses after fixed duration therapy? It's reassuring that those patients have not developed resistance mutation. So in 40 patients, nobody had developed a CYS481 mutation or a G101 venetoclax resistance mutation. And this is encouraging for the field to further move to time-limited therapy to prevent the possibility or probability of developing resistance mutations. And we saw that after re-exposure to the very same agents that patients got in their time-limited therapy, they're still experiencing very high response rates. And last but not least, in the frontline setting, I do want to touch upon the Elevate-TN study. The 6-year follow-up results was presented, but I'm going to tell you what I'm going to focus on this trial because the results have been published before, not the 6-year follow-up, but the shorter follow-up. So Elevate-TN, treatment naive, was a trial in older patients or young patients with multiple comorbidities with treatment-naive disease who got randomized to acalabrutinib plus 6 cycles of obinutuzumab versus single-agent acalabrutinib versus a combination of obinutuzumab chlorambucil. And the primary endpoint of the study was PFS, and crossover was allowed. If patients in the chlorambucil obinutuzumab arm progressed, they could actually cross over to the single-agent acalabrutinib arm. And here you see that with 6 years follow-up, the 6-year PFS in the acalabrutinib plus obinutuzumab was 78%, versus 62% in single-agent acalabrutinib versus 17% in obinutuzumab chlorambucil. And although, this was a post-hoc analysis, but here you see a 16% difference in the progression-free survival between the acalabrutinib-containing arms, raising the question that what it is that the results are pretty different in patients who are receiving this very same BTK inhibitor, but in one group they're receiving a CD20 monoclonal antibody and the other group they are not.
I just want you to tell me where the zanubrutinib monotherapy arm fits in.
That's a great question.
But really.
Yeah. I mean, this is the thing. Zanubrutinib was compared to BR, and I will basically show you when it's compared to single agent ibrutinib in the Alpine trial in the relapsed refractory setting, but the results are very much similar. But I caution, I am not, kind of a doctor who sees the Elevate TN results and assume that, you can basically use any covalent BTK inhibitor. I'm an originalist. I really stick to data, how it was presented and how it was done, because, yes, there are the same class of drugs, but they're not necessarily the very same drugs. So I caution everyone from interchangeably using, another covalent BTK inhibitor, because acalabrutinib, for example, was investigated in Elevate TN, assume that the results are going to be very similar with zanubrutinib. We cannot really answer that very question unless we run the very same trial with zanubrutinib, or we basically have a head-to-head fashion.
Are there any data in terms of anti-CD20 plus zanubrutinib?
Not that I know of.
Wow.
I know there. Yeah, I know there. Zanubrutinib, the Sequoia trial was BR versus zanubrutinib, and there was a cohort for 17p deletion, which was single agent zanubrutinib, and they also had a doublet zanubrutinib plus venetoclax arm. And I know investigator-initiated trials that are investigating zanubrutinib combined with tafasitamab, which is CD19 monoclonal antibody.
So just kind of curious, because, of course, like you say, we don't know. We don't have a direct comparison. But, the one place that I hear anti-CD20 talked about is like the younger patient, you want to, whatever, that can tolerate it and, maybe wants everything possibly done. For a patient like that, would you do, I don't even know in general what your usual covalent is, but would you do acala plus obinutuzumab or Zanu?
That's a great question. So I try to run a data-driven clinic. So I tell them about the, 6-year PFS of 78% versus 62%. So there is a 16% difference. If someone is enthusiastic to get the obinutuzumab because they believe in this data, I use obinutuzumab if someone is presenting with autoimmune cytopenias, particularly ITP or autoimmune hemolytic anemia. I try to combine that with the covalent BTK inhibitor. And the other scenario that I see myself using it is when there is a huge disease burden, and then we know adding a CD20 monoclonal antibody results in faster response and also a deeper response, as I am going to show on the next slide. So a lot of it is, again, mutual decision making. That's the beauty of CLL. We have all the data, and a lot of it is presenting the data as it was presented to patients and try to see whether they're open to it or not. So here you see that in the blue arm, acalabrutinib obinutuzumab, you see that the overall response rate was 96% as compared to the red line with an overall response rate of 90% with single agent acalabrutinib. And this difference is mainly driven by a difference in CR rate. So the CR rate, as shown in the green line, was 36% in patients with acalabrutinib plus obinutuzumab versus 19 patients. So there is a 17% difference. So the question is, with this difference in CR rate, is it patients with CR, is the CR driving the PFS benefit? And they answered that question in the next slide. And here you see, regardless of what patients got, acalabrutinib single agent or acalabrutinib plus obinutuzumab, patients who did actually achieve CR, they had better PFS outcomes, as shown in the blue line, compared to patients who did not achieve CR, whether it was single agent acalabrutinib or combination of acalabrutinib plus obinutuzumab. So, and then they looked at the impact of IGHV status and 17p deletion, and they realized that in patients with unmutated IGHV receiving acalabrutinib single agent, as shown in the middle graph by red, so patients with mutated or unmutated IGHV status did not differ, receiving single agent acalabrutinib or receiving acalabrutinib plus obinutuzumab. But when you look at the deletion 17p and or TP53 mutation on the lower graph, you'll see that it really didn't matter in patients who received single agent acalabrutinib. In patients who received obinutuzumab plus acalabrutinib, as a matter of, interestingly, patients without TP53 aberrant disease, those were patients who responded better, who had better PFS outcomes by the addition of obinutuzumab. So if the thinking is the patient has TP53 aberrant disease, let's go with all our guns, this very graph proves us wrong, because patients without deletion 17p who actually got obinutuzumab had better PFS outcomes compared to patients who did not have TP53 aberrant disease. And here you see the 6-year overall survival is pretty similar in single-agent acalabrutinib versus obinutuzumab chlorambucil versus obinutuzumab plus acalabrutinib, but there is a trend toward improved overall survival in patients who received acalabrutinib plus obinutuzumab. And then there is a lot of fear in the community. Obinutuzumab is associated with toxicities. And here you see that, understandably, the rate of neutropenia was higher in patients who received a combination of acalabrutinib plus obinutuzumab versus acalabrutinib. Also, thrombocytopenia was higher in patients who received BTK inhibitor plus CD20 monoclonal antibody. The rate of COVID was not different, with the caveat that the last patient was put on the trial in February 2017. That's 3 years before the global pandemic. And by the time of the pandemic, the effect of the monoclonal antibody was already gone in this patient population. So some highlights: the addition of obinutuzumab to acalabrutinib. We know that it does result in faster and deeper remission, particularly achieving higher CR rates and longer PFS. But how clinically meaningful that is to us as clinicians and to patients. And I think that can be decided on a case-by-case basis from our conversation with patients. And I do want to emphasize that the addition of obinutuzumab to acalabrutinib did not affect PFS outcomes in patients with TP53 aberrant disease. And then it's your decision. The 6-year PFS was 78% in A plus O versus 62% in single agent acalabrutinib. The question is this difference in a post hoc analysis? And please remember, this is a post hoc analysis, worth putting a patient through, a CD20 monoclonal addition to acalabrutinib or not? And I think a lot of the answers depend on what patients want and what feels right to you as a clinician. And I will conclude the frontline section by going through what to watch for in the frontline setting in the near future. Amplify is most likely going to be presented at ASH 2024. Amplify is a randomized clinical trial in patients with previously untreated CLL without TP53 aberrant disease and a good performance status. And the patients got randomized in a 1:1:1 fashion to doublet acalabrutinib plus venetoclax, fixed duration up to 1 year. The study has an arm for triplet therapy, acalabrutinib plus venetoclax plus obinutuzumab, and also chemoimmunotherapy, FCR or BR. And the chemoimmunotherapy arm is the reason that patients with TP53 aberrant disease got excluded. The primary endpoint is PFS. And then another very good study that is going on. I don't have any conflict of interest because, unfortunately, we don't have this trial open at Stanford, but I think it's a very neatly designed clinical trial, is the MAGIC trial. MAGIC trial randomizes patients with treatment-naive CLL in a 1:1 fashion to receive the CLL14 regimen of obinutuzumab plus venetoclax. At the end of therapy, patients get checked for MRD. If they are UMRD, they stop treatment after 1 year. If they still have positive measurable residual disease, they get an additional year of venetoclax, single agent venetoclax, for a total of 2 years of venetoclax therapy. And then in the doublet arm, acalabrutinib plus venetoclax, patients get 2 cycles of acalabrutinib, and then they get 12 months of the combination therapy. And at 14 months, they get checked for MRD. If they're MRD positive, they'll continue the doublet therapy for an additional year. If they're doublet negative, they'll stop treatment.
Just a quick question. It seems kind of strange to have a trial that's got FCR and BR in one arm. I mean,
I do agree with you.
Would you be comfortable putting a patient on that?
I am not comfortable. I think people might still be comfortable in the mutated IgHV patient population, but the study did not exclude unmutated IgHV patients. All the trial did was exclude patients with TP53 aberrant disease. My honest answer is I am not comfortable giving any patient with unmutated IgHV chemoimmunotherapy under any circumstances, unless, I have I have had these patients in the past, a homeless or unhoused patient who, doesn't have a, place to keep their oral therapy, and, time-limited chemoimmunotherapy is an option for them. And I have given bendamustine rituximab to a patient with unmutated IgHV status who did not have the financial resources or, the social support to get oral therapy. But outside those really rare circumstances,
I mean, no problem with BR, but it's the FCR that, I mean, quality life-wise, and so I don't know. But anyhow.
Yep. I share that sentiment with you. Yep. And the follow-up, the 6-year follow-up of the Alpine trial was presented by Dr. Brown. Just to remind everyone, Alpine was a phase 3 trial for patients with relapsed refractory CLL who had seen at least one prior line of therapy, and they required treatment per IWCLL criteria. And the key exclusion criteria, the patients had to be BTK inhibitor naive. They shouldn't have seen a BTK inhibitor in the past, and they got randomized to zanubrutinib at 160 milligrams twice daily versus ibrutinib at 420 milligrams daily. And here you see that 327 patients got randomized to zanubrutinib, of whom 194 patients are still undergoing treatment, as compared to 152 out of 325 patients in the ibrutinib arm. The rates of discontinuation were higher in the ibrutinib arm as compared to the zanubrutinib arm. And here you see that they're presenting a 3+ year follow-up results this year as compared to 2-year follow-up results last year. And at 3-year follow-up, the 3-year PFS is 65% in the zanubrutinib arm versus 55% in the ibrutinib arm. And this difference was more prominent in patients with TP53 aberrant disease. The 3-year PFS for patients with TP53 deletion/mutation in the zanubrutinib arm was close to 60% as compared to 40% with ibrutinib. And last year, many of us thought, okay, if you have a better tolerated BTK inhibitor, the patients are going to stay on that BTK inhibitor for a longer time, and they're going to have improved PFS. So to address some of those concerns, the trial did multiple sensitivity analysis, including accounting only for disease progression or death while on therapy, and also censoring for new CLL therapies and censoring for death due to COVID. And in all those sensitivity analysis, the hazard ratio favored zanubrutinib as compared to ibrutinib. And here you see that in terms of overall response rate was higher in zanubrutinib as compared to ibrutinib. And the overall survival is almost similar between the two arms. And in terms of toxicities, you see that COVID-19 related toxicities, interestingly, were more frequent with zanubrutinib compared to ibrutinib. And when Dr. Brown was asked that question, my understanding is nobody has a very good explanation why that is. Neutropenia, the rate of neutropenia is slightly more in zanubrutinib arm compared to ibrutinib arm. The rate of hypertension, interestingly, is similar between zanubrutinib and ibrutinib. We know that hypertension is a late toxicity. And the other very important toxicity is any grade atrial fibrillation happened at 16% with ibrutinib as compared to 6% with zanubrutinib. And the discontinuation due to cardiac adverse events were also higher in the ibrutinib arm. And here you see that although the cumulative incidence of hypertension is similar between the two arms, as shown in the left graph, when they looked at the delta, the change in systolic blood pressure, they found that the change in systolic blood pressure was more pronounced with ibrutinib as compared to zanubrutinib. Nevertheless, the rate of hypertension was similar in both arms. So, talking about double refractory patients, when covalent BTK inhibitors and BCL2 inhibitors, both classes of agents, fail a patient with CLL, what next? that's when CAR T can become basically a viable option. And I anticipate the liso-cel getting FDA approval for this very indication this year. Just focusing on the double refractory cohort, the trial had 50 patients who got the liso-cel product at dose level 2, and those patients were double refractory. And the primary endpoint was CR, or CR with incomplete count recovery. And here you see that the CR rate was 20% with an overall response rate of 44%. And, this is really interesting that the rate of UMRD, 64%, is higher than the CR rate, meaning a larger basically number of patients achieved UMRD without necessarily getting into nodal remission, meaning their lymph nodes never got to less than 1.5 centimeters, which is a CR requirement by IWCL assessment criteria, response assessment criteria. But those are patients who have actually achieved UMRD. And here you see that 19 out of 32 patients with stable disease, patients who, based on the classic IWCLL criteria, have not achieved CR or PR, their stable disease, but 60% of those patients have achieved UMRD, and we know from other trials from the German group that, in patients who achieve UMRD, those patients progress basically at less or later, independent of their CR or PR status. And it is important to know that the median time to next therapy in the double refractory patient population was 12.4 months. Not as good as what we see in CAR T trials in lymphomas, in aggressive lymphomas like diffuse large B-cell lymphoma. But it is important to remember that patients with CLL, they have inherently dysfunctional T cells. And no matter what technique you use to make those inherently dysfunctional CLL lymphocytes smart, at the end of the day, they're dysfunctional. And that might explain why we are not seeing really outstanding results that we see with CAR products in other aggressive lymphomas in CLL. Nevertheless, here you see that in the double refractory patient population, the black line shows that the median progression-free survival was 12 months. And this means that patients take, CAR T, and potentially they enjoy a 1-year remission, the median progression-free survival 12 months. I am not one of those clinicians who label CAR T as one and done. The cell infusion happens once, but we now know that patients potentially can develop prolonged cytopenias. They can develop hypogammaglobulinemia requiring therapy, treatment. So it is important to present the data as is to patients. And here, there was another abstract that showed undetectable MRD status in patients with stable disease after liso-cel, and patients with high liso-cel expansion achieved UMRD, regardless of, on the left side, you see disease burden defined by peripheral CD19 positive cells. In the middle one, they achieved UMRD independent of their nodal disease burden, and on the right side, independent of the CLL involvement percentage in their marrow, which again is promising. So CAR T is definitely an option. And in terms of other potential options in the double refractory patient population, pirtobrutinib, the first non-covalent BTK inhibitor, presented its 30-month follow-up for the double refractory patient population. And just to give you an idea of what pirtobrutinib is in lay terms, yes, we have the covalent BTK inhibitors. It's important to understand the mechanism of action. So covalent BTK inhibitors, they're irreversible. They form a covalent bond between the covalent BTK inhibitor and the BTK, the C481 site of the BTK. So if a mutation happens in C481 site, because the drug is not able to form a covalent bond with the C481 site, it's not going to be able to exert its function. That's when non-covalent BTK inhibitors come into play because they're more liberal in their action. They bind, unbind, rebind. They don't necessarily require that intact BTK to be able to exert their function. That's why response to pirtobrutinib, it has previously been shown that it is independent of BTK resistance with CYS481 mutation. It is effective in both wild type and also C481S mutated patients. So the 30-month follow-up focused on the 282 patients on the BRUIN trial had seen a prior covalent BTK inhibitor. And of these 282 patients, 128 had seen a covalent BTK inhibitor and also a BCL2 inhibitor, what we label as double exposed or double refractory patient population. This is a heavily pretreated patient population, as shown here, with a median 5 prior lines of therapy ranging between 1 to 11. The majority of patients had high-risk features, as evidenced by half of those patients having TP53 aberrant disease, and almost all those patients, 93% of those patients, having unmutated IGHV. And in this heavily pretreated patient, enriched in high-risk features, you see that the overall response rate is still 80%. And if we look at the median progression-free survival, you see that on top for all comers, the median progression-free survival was about 19 months. And for the double exposed or double refractory patients, the median progression-free survival is almost 16 months. So CAR is not yet FDA approved, but there is a very real possibility that it's going to happen soon this year. So the median progression-free survival for double refractory patients with liso-cel was 11.9 months. With pirtobrutinib was 15.9 months. Again, I am not here to do any cross-trial comparison, but when we get to a double refractory patient, so if you're practicing in the community, my sincere wish is to just refer that patient to an academic center. Those patients need to get on the clinical trials, and we need to learn how to sequence the currently available options or, other agents that are being investigated in clinical trials. But if you have an old patient or a frail patient or a patient who doesn't want to commute to an academic center, pirtobrutinib and liso-cel are potentially viable options with the data that I presented.
So just a couple questions. What about the issue of bridging to CAR T, and do you ever use pirtobrutinib to do that?
That is a great question. So we know that, for that particularly double exposed, double refractory patients, a good number of those patients, when we are considering them for CAR T, their disease is raging and they really need some partial control because the manufacturing takes some time, about 4 weeks. So how to basically hold them. I definitely do not use chemoimmunotherapy. Sometimes I use a PI3 kinase inhibitor like duvelisib until their product is ready and they're ready to go. Sometimes, they're still responding to their covalent BTK inhibitor. They're progressing, but you know that the resistance mutations mostly happen at subclonal levels. So you cannot keep those patients on covalent BTK inhibitor for a long time, but the covalent BTK inhibitor can provide some temporary response so that their disease does not explode. So in those patients who are still having partial disease control on their covalent BTK inhibitor, I tend to continue their covalent BTK inhibitor. And I do not use pirtobrutinib as bridging therapy because the thing with pirtobrutinib, they'll take it. It's a very well-tolerated non-covalent BTK inhibitor, and they feel better. And their question is, why can't I just continue with, pirtobrutinib, So I do not recommend using pirtobrutinib as bridging therapy. I would take all the mileage that I can from pirtobrutinib and then take patients to CAR T therapy. And right. Even, I have to mention on the BRUIN trial, 12%, 15 patients in the double exposed, double refractory group, they had seen prior CAR T. So the double exposed, double refractory cohort on the BRUIN trial included patients who had progressed after CAR T.
Another question, am I correct in saying that CAR T itself in some way leads to cytopenias?
So not itself, but it is a real complication that these patients, how we are using CAR T right now, the T cell exhaustion is real. We are using it as a later line of therapy. A lot of the patients who got on the Transcend CLL-004 trial are the older patient population with CLL, meaning by old, I don't mean necessarily age-wise they're old, but they had their diagnosis prior to 2014 when targeted agents became available. So these are patients who have seen chemoimmunotherapy in the past. So it's not necessarily a representative of the contemporary CLL patient population. Our patients with more recent CLL diagnoses, those are patients who have not seen chemoimmunotherapy in the past. Their CLL journey started with targeted agents. And it's very interesting for me, for the field, to see how these patients who have not seen chemoimmunotherapy in the past are going to respond to, these agents.
Well, that leads to my last question about CAR T, which is whether or not you think there's a plateau in the curve. And I guess the issue would be maybe there's a plateau that you need to look for within that. I don't know.
I agree with you on that. In patients who actually achieve CR, there is definitely a plateau. But in patients who do not achieve CR, which, are basically, here you see 40 out of 50 patients in the double exposed, double refractory patients, those are patients who progress. So it is, I'm cautiously optimistic in patients who do achieve CR after CAR T. It might be, right to say that those are patients who, when speaking about functional cure, quote unquote, those are patients who can potentially be cured with CAR T. But the problematic patient population are the high percentage of patients who do not achieve CR. The CR rate, as I presented in the slide, was 20%, and the overall response rate was 44%. So I do think, yes, I'm very happy that CAR T is going to become a viable option for double exposed, double refractory patients, but we should and we can do better with cell-based therapies in CLL patients. And I think that's when allogeneic CAR T trials come into play because, you don't have that T-cell dysfunctionality in allo CAR T trials. I am curious to see how the long-term results of bispecific T-cell engagers is going to read out in CLL patients.
Yep. Please continue.
I want to briefly mention some novel molecules that were presented at ASH, but they're definitely not ready for clinical practice. Just to make sure that we've all heard of them, there's a very exciting new BCL2 inhibitor, sonrotoclax. Sonrotoclax has a greater tenfold potency compared with venetoclax and better in vitro activity against BCL2 mutations, particularly G101V, meaning it can potentially overcome the venetoclax resistance. And it also has a shorter half-life, which allows for a more rapid ramp-up. We know that the venetoclax ramp-up, at least how it was done in the clinical trials, both Murano and CLL14, is a 5-week ramp-up. But this phase 1/2 study of sonrotoclax plus minus zanubrutinib investigated doses between 40 to 640 milligrams, and they had 2 dose escalation patterns, daily and weekly. And they had 2 cohorts, CLL and mantle cell lymphoma. And for CLL, they enrolled patients with treatment naive and relapsed refractory disease. And you see that at dose level of 320 milligrams, the overall response rate was 100%, with 1/3 of patients achieving CR. And the best overall response was, again, 100%, with 32% of patients achieving CR. And based on the results of this phase 1/2, they are opening a new phase 3 trial, a very well-designed phase 3 trial, combining zanubrutinib plus sonrotoclax, so a BCL2 inhibitor and a BTK inhibitor, time-limited fashion. That's the investigational arm. And the other arm is the CLL14 regimen, obinutuzumab venetoclax. So whoever gets on that trial is going to get the best possible care because we already know the 6-year follow-up of the obinutuzumab venetoclax. And I am curious to see how a new BCL2 inhibitor is going to pan out in the field. And the other molecule that I want you to have heard about, and hopefully in the next few years, the results are going to get more mature, was presented by Dr. Vayak from Ohio State. And this is the first basically covalent and non-covalent next generation inhibitor of BTK the molecule doesn't have a name yet, LP168. And it actually has, in patients with wild type BTK, it forms a covalent bond with BTK. And in patients with CYST481 mutated, it behaves like a non-covalent BTK inhibitor. And here you see that the numbers are really small. So I don't want to, get into the details, but promising early results and a molecule to be watched in the next few years. And last but not least, talking about Richter's, the German CLL study group presented tislelizumab, which is an anti-PD-1 inhibitor, combined with zanubrutinib in patients with Richter's. This audience knows that Richter's happens in about 2 to 10% of patients with CLL and remains a truly unmet need in the field of CLL. And from different registries, we know that the median overall survival is 3 to 10 months. And the trial design was tislelizumab every 3 weeks, combined with zanubrutinib, 160 milligrams twice a day, continued until disease progression or intolerance, with the primary endpoint of overall response rate. Those of us who run Richter's trials know that it's a huge effort to put a patient with Richter's in clinical trials, because unfortunately, by the time we get them from community, they've already been started on a treatment. So let me beg you, if you have a patient with Richter's, just call your academic center and refer those patients. Those patients are not going to do well with anthracycline-based therapy. If there is one thing we've learned, their median overall survival with, anthracycline with R-CHOP-based therapies is 3 to 10 months. It's not good. So chemoimmunotherapy is not going to work in clonally related Richter's transformation. So the trial enrolled 65 patients, and here you see only 48 patients were able to get at least one dose. And that's the reality of Richter's trials. You screen patients pass away before getting any dose. So it's a huge effort, and I really commend the investigators for their effort. And, their null hypothesis was anything with overall response rate less than 40% is going to basically not make the study worth going forward. And with an alpha of 0.05 and a power of 80%, they had to enroll 48 patients. And here you see the characteristics of this patient population. About 1/3 of patients had TP53 deleted or mutated status. And the majority of patients, 70% of patients, had unmutated IGHV. 2/3 of patients had high LDH. And as you see by the SIRS score, these are patients who are sick. And about 40% of these patients have complex karyotype. And about, again, more than 50% of these patients, based on the CLIPI score, they have high or very high CLL-IPI score. And in terms of prior lines of therapy, this was a heavily pretreated patient population. They had seen allogeneic stem cell transplantation in the past. About 90% of the patients had seen either a BTK inhibitor or a BCL2 inhibitor, with 2/3 of patients having seen a BTK inhibitor in the past. It is important, even in patients who had seen a covalent BTK inhibitor for their diagnosis of CLL in the past, there was still response when they're transformed to diffuse large B-cell lymphoma. And about 5% of patients had seen both BTK inhibitors and BCL2 inhibitors. And I also want to bring it to your attention that 2 out of 48 patients had Hodgkin lymphoma. So it was not only for diffuse large B-cell lymphoma. We know about PD-1 expression, overexpression in Hodgkin, and we know about BTK inhibitors in CLL. So I'm really glad that they opened it to also patients with Hodgkin's transformation. And in terms of adverse events, no atrial fibrillation from zanubrutinib in a total of 57 patients. 3 patients had developed hypertension from zanubrutinib, 5 cases of bleed, 1 actually cerebral hemorrhage, which was grade 3. And in terms of immune checkpoint inhibitors, the autoimmune adverse events that are associated with immune checkpoint inhibitors, 2 patients had developed hypothyroidism and 5 patients transaminitis. So nothing crazy in terms of toxicities. And the overall response rate was 58%. And this is important because their null hypothesis was overall response rate of less than 40%. The median duration of response was not reached. I want to pause on these graphs. So the median PFS for patients who actually got treated was 10 months. But they were very honest, and they presented the median PFS for all comers, because I showed that a good number of 65 out of 65 patients who got screened for the study, 48 patients were able to get dosed. So for all those 65 patients, which are a closer reality to what we see in Richter's in real life, the median progression-free survival was 6.7 months. And the overall survival for all comers, the 12-month overall survival was 74%. And for patients who even did not get dosed, again, the 12-month overall survival was shown on the right, and the median overall survival was not reached. So the trial went live a few minutes before the presenter, Dr. Al-Sawaf, presented the study. And I am curious to see, what we have available for patients with Richter's right now. Last year, pirtobrutinib presented a good number of patients with Richter syndrome, DLBCL transformed Richter's, who got pirtobrutinib, and some of those patients used pirtobrutinib as a bridge to allogeneic stem cell transplantation, which is potentially curative for patients with Richter's. Epcoritamab presented really low number. I believe they presented at ASH 2022, 10 patients with Richter's, and about half of those patients achieved CR and proceeded with more permanent options. So bispecific T-cell engagers are going to evolve in Richter's. We have the non-covalent BTK inhibitors, and now we are seeing an increasing number of anti-PD-1 inhibitors plus covalent BTK inhibitors. We know that the MD Anderson group investigated nivolumab plus ibrutinib. The Mayo group investigated acalabrutinib plus pembrolizumab. I think the German CLL study group, they just have the advantage of numbers. They go and they enroll in Europe, and they're very collaborative. So they're able to present, such high number trial for Richter's. I think 65 patients for Richter's is a success. And just to wrap up, in the treatment naive setting, I presented the 6-year follow-up of the Elevate-TN trial. I did go through the 6-year follow-up of the CLL-14 trial, which was presented at EHA. In terms of doublet therapies, we talked about the 5-year follow-up of the Captivate trial with a particular focus on the 53 patients out of 202 patients who progressed after fixed duration therapy. We talked about the GLOW trial, which was fixed duration ibrutinib plus venetoclax versus chlorambucil obinutuzumab, the UK FLAIR, and their very sophisticated mathematical model based on MRD approach was presented. I did present the median 39-month follow-up of the ALPINE trial in the relapse refractory setting. And in terms of options for double refractory patient population, we did talk about the 30-month follow-up of non-covalent BTK inhibitor pirtobrutinib in double exposed patient population. And I also presented the double exposed cohort of the Transcend CLL 004 trial. And, there are so many abstracts, but I think the ones that we talked about, these are the abstracts that I really enjoyed reading, if you're interested to go into them in depth. But I think the trials that we talked about, and I tried to elaborate on the results, are the trials that are going to shape the treatment landscape for CLL in the next few years. And with that, I'm more than happy to answer questions.
Well, I see that you've got a case, and I really love the case. So you want to finish with that? I guess that's
Absolutely.
Your case, right? The 81-year-old man?
Absolutely, yes. It. So, yes, an 81-year-old gentleman with CLL. And in terms of tumor biology, he has deletion 17p and unmutated IGHV. He has seen ibrutinib in the past for 6 years. So this is a person who started their CLL journey on oral therapy. And they had disease progression, and then they started venetoclax-based therapy with disease progression 3 years after the venetoclax course was concluded. So this patient comes to you, they're 81, they're interested in oral therapy. How would you advise? And I'm happy to go through basically options. The first option is a new generation covalent BTK inhibitor, acalabrutinib or zanubrutinib. this would not be my pick because, this patient has already progressed on another covalent BTK inhibitor. So a patient who has progressed on a previous covalent BTK inhibitor is not going to respond to another covalent BTK inhibitor. And then convince the patient to proceed with CD19-directed CAR. How some people advertise it as one and done. That's not how I would advertise it. And I would go through, it's a good option if someone is motivated and they are acutely aware of the acute toxicities, CRS, and neurotoxicity. And they're also aware of the late toxicities, hypogammaglobulinemia, infections, cytopenias happening after CAR-T, which might require frequent office visits. So I caution the field to label CAR-T as one and done. And, I wouldn't pick this because in the question stem, the patient is interested in oral therapy. Option C is pirtobrutinib, choice C is pirtobrutinib, which we talked about. And I think he actually is the right candidate for pirtobrutinib. He is double exposed. You might argue that he's not necessarily double refractory because his disease came back 3 years after conclusion of venetoclax therapy. So pirtobrutinib, we saw that in the double exposed patient population, the median progression-free survival was 15.9 months. And I also want to bring it to your attention that, if their disease progresses after 16 months, it doesn't necessarily mean that they have to get off ibrutinib. Sometimes the progression is more gradual and they can remain on that non-covalent BTK inhibitor. The rechallenge with venetoclax, let me just be very clear. There is no clinical trial data for that. Dr. Matt Davis at Dana-Farber, they are running the revenge trial, which is rechallenging with venetoclax and obinutuzumab in patients who have had previous venetoclax exposure, but they were able to enjoy a PFS of 2+ years. So it might make sense for this gentleman to get rechallenged with venetoclax, but the question that has not been answered in the field is, okay, the first venetoclax was time limited. In his case, he probably got 2 years because he got venetoclax in the relapsed refractory setting based on Morano. But what is the duration, the right duration of venetoclax-based therapy in a patient who has seen previous venetoclax? Are we going to give it randomly for 4 years, give it for another 2 years? And I am personally not comfortable with, just random practices in medicine. So I think it is an important question, and I know that the field is going to be able to answer that question in the next few years. And the last option is PI3 kinase inhibitors. On paper, they're definitely an option, duvelisib and idelalisib, but unfortunately, PI3 kinase inhibitors are associated with very high rates of toxicities, autoimmune hepatitis, pneumonitis, colitis. And what good is a drug if a patient cannot tolerate that drug? So in an 81-year-old, in the presence of much better tolerated options, I would not choose a PI3 kinase inhibitor. In my practice, I choose a PI3 kinase inhibitor, as we talked about, as a bridging therapy to a more permanent option.
What do you think the optimal management would be?
I think pirtobrutinib. This is a patient for whom pirtobrutinib got the accelerated approval in the beginning of December, and providers are not going to have any issue ordering pirtobrutinib. So I think pirtobrutinib at 200 milligrams daily, very well tolerated in terms of side effect profile, and also will provide the patient with a pretty durable response.
So just a couple of final questions. For patients like this one, who got BTK and then got venetoclax, like how long after receiving venetoclax does a relapse have to be to differentiate between refractory or not?
That's a great question. So I think, it's really arbitrary, but I think the field has come to using 2 years. We call it the PFS 1 of 2 years, meaning the PFS from the first venetoclax exposure, if it's 2 or plus 2 years, there is a very high likelihood that that patient has not developed resistance to venetoclax. But if a patient is progressing earlier than 2 years following completion of therapy, there is a high likelihood that that patient has developed, resistance mutations, with G101V being the most common resistance mutation to venetoclax.
In this situation, or even the first time you would use venetoclax, are there situations where you would consider using it without CD20?
Yes, older patients who I feel like whose disease are who are not at a very high risk of tumor lysis syndrome based on their nodal burden and their marrow burden, I am comfortable using single agent venetoclax. But in the relapse refractory setting, I normally do how the Murano trial did, combining it with CD20 monoclonal antibody. But if I have any reason to feel uncomfortable combining venetoclax with CD20 monoclonal antibody due to age, due to comorbidities, especially in the beginning of the pandemic, when patients could not develop any antibody, long after CD20 monoclonal antibody exposure, I was more comfortable dropping CD20 monoclonal antibody. So in short answer is, in patients with low disease burden that I'm less concerned about tumor lysis syndrome, in old and frail patients with frequent comorbidities, I am comfortable just doing single agent venetoclax and not necessarily increasing it to maximal dose of 400. I sometimes just keep them at 200 milligrams or a dose that they can tolerate, because again, what good is a medicine if a patient cannot tolerate it? So it's important to just, dance that dance with the patient, just see what they're capable of tolerating. And sometimes, there are patients who have good disease control at lower doses, not necessarily 400 milligrams.
I mean, I think from a quality life point of view, particularly once you bring in obinutuzumab, it's changing things, not just the infusion, but, all the stuff that goes with it. I'm not asking for a number, but, I know there are people who don't use, anti-CD20, not too many, even first line. Like, how much additional benefit do you think you get from the anti-CD20? Like a little bit, a huge amount?
That's that's a good question. It's a great question. I do think addition of CD20 monoclonal antibody will result in a deeper response, in a higher CR rate, and it'll result in a faster response. So if you basically have bulky lymphadenopathy at risk of, obstructive uropathy, then it makes sense to combine a CD20 monoclonal antibody before you get to that end organ damage. But the question is, does everyone need to be in CR to have disease control? No, not everybody needs to be in CR to have disease control. So a lot of it is clinical judgment, I believe. I use, again, CD20 monoclonal antibody if someone has really high disease burden and I'm worried about end organ damage. I use I combine CD20 monoclonal antibody if someone has Evans syndrome, autoimmune vasculitis, autoimmune, hemolytic anemia, ITP, autoimmune arthritis. We see that in patients with CLL. Or in someone who, is really young and fit and capable of tolerating a CD20 monoclonal antibody.
So final question, you seem pretty comfortable thinking about the possibility of CAR T in this 81-year-old man situation. How old? I mean, people say age is just a number, but I mean, it gets to be a point where it gets to be more than a number. But just kind of curious how you, vision criteria to use CAR T in CLL.
Yes, I tend not to have an ageist approach in my practice, but the reality is, I don't remember, but I had heard this from people in the past that bone marrow has worked for 81 years in his case. Yeah, he might look, 65 years to us, but the bone marrow has been working for 81 years. So I do consider age pretty, not as a solo deciding factor, but
I pause in an 81-year-old for going into CAR. And I know that, the CAR T trials did not have any age limit. They left it to the investigator's judgment to include, comorbidities and performance status and all those factors and not exclude someone based on age. This is not an allogeneic stem cell transplantation or an auto stem cell transplantation, but I would be more cautious, especially the, product that is currently available or is going to get FDA approval is lysocaptogen marrow-cell. And I didn't show the toxicity slide, but it is associated with high CRS rate and high neurotoxicity. So I would consider lysocell when it gets approval in, I wouldn't say young and fit, but at least more fit patients who are at a lower risk of developing short and long-term toxicities.
I guess you're being focused on the CLL, probably don't have much experience with axi-cell, but it seems like lysocell is better tolerated, but I don't know what that means in terms of, the typical CLL patient.
Yeah, I mean, the plural of anecdote is not data, but that was my anecdotal experience also, that lysocell, yes, in terms of axi-cell and tisocell and lysocell, tisocell was the best tolerated, but there was some efficacy questions comparing axi-cell, tisocell, and lysocell. So leaving us with axi-cell and lysocell, yes, lysocell, again, we haven't compared in a head-to-head fashion, but from what we are gathering is the seemingly better tolerated CAR T product.
This concludes our program. Special thanks to Dr. Fakhri, and thank you for listening. This is Dr. Neil Love for Oncology Today.